Hey, welcome everybody. What we're going to talk about here is our musculoskeletal disorders. So you'll have a couple of different PowerPoints to view. I'll try and chunk them into the different main categories that you'll have on your outline. But what you'll need to do, since this is an online week, is you'll have to read your material, like you always have to. You can watch the lectures here online that I posted with screen capture. And then you have your blog assignment that's tied to this material as well that you'll need to complete, and it will be due after holiday break. All right, so we're looking at musculoskeletal disorders. So that means we're going to be talking about things that are going to damage our muscles, our tendons, our ligaments, and our skeleton. Fractures are what we usually think of. So you think about musculoskeletal disorders, you think about broken bones usually as a common cause of disorders that go with our skeleton. So we can have other injuries as well too. So we think about strains. That's where we're going to do something that's going to stretch a muscle because we've overloaded it. So think of it literally putting a strain on that muscle. Sprain involves our ligaments. So instead of the muscle, we're talking about a ligament injury. And that's the main difference between strains and sprains. Dislocation would be where we've separated or displaced the bone at a joint. So the end of the bone comes out of a socket, for instance, and you're not able to move it, so you have loss of articulation. And then fractures would be where you're going to have breaks within the bone. So for fractures, it's actually a disruption or a break in the continuity of the structure of the bone. So it can be the whole way through, it could be partially through, it can be at an angle, there can be different types. Traumatic injuries account for the majority of our fractures, so sports injuries, falls, accidents, things like that. When we look at our fractures, how we describe them, we use some different things to classify them. So how do we know where they're at and what we're talking about? First would be the type of fracture. Then we want to look about whether it's communicated or non-communicated with the external environment. So you might hear things called like an open fracture. That would be where it's communicating with the environment. So the bone has literally broken and is coming through the skin and the muscle layers and is actually protruding. And then the anatomic location. So is it on the right side, the left side? Is it your arm? Is it your leg? That type of thing. And then the alignment of the fracture. So what way does it actually break? So here are different types of fractures you can have. Okay, so for instance, a spiral fracture actually happens whenever you're having a spiraling motion on a bone. This is one of the ones that's actually common whenever we look at child abuse cases. So if we see this fracture, we're concerned that there might be negligence or abuse going on. Displaced would be where you can see it's cracked the whole way through and then the two ends aren't together anymore. So you can have a bone where it's cracked, okay, but it stays together. So for instance, L, where it's transverse, the two ends still meet up. Displaced means that it's broken the whole way through and now the two ends aren't together anymore. We would classify the fracture by its location too. So where at on the bone are we going to be talking about? So for instance, if we're looking at a tibia, right, we would want to know whether it's in the shaft part of the bone or the middle third, or is it at an end, okay? Is it in the distal end or the proximal end? A stable fracture is when a piece of the periosteum is still intact across the fracture. That means it hasn't completely displaced. There's still some part of it that is able to be aligned and intact. Unstable then would be like our examples on the transverse and oblique then, where their bones are not, there's no part of the bone that's intact anymore, and it has more likelihood of becoming displaced or dislocated and be unstable then. So the mechanism of injury, we want to know what happened to the injury because it's going to often be what's going to help us associate the clinical manifestations. So a lot of times, and if you've ever broken a bone, you're going to probably know a lot of this firsthand, you have an immediate localized pain. So of course you displace that bone, you have increased swelling, we have edema at that site, we have pressure and disruption of our nerve signals, and then you're going to have pain sensation. You're not going to be able to move it. You have a loss of function probably. Maybe you can use a little bit of function if the muscles and tendons are intact, but you're not going to have your complete function anymore. You're not going to be able to bear weight or use the affected part effectively or at all. They're going to probably be guarding, meaning that they don't want people to touch it, and you may even have a deformity. Like if you look at this image here where the bone has broken and has become displaced, you can actually see a physical change in the appearance of the area affected. When we have bones that break, then we ideally want our bones to heal, right? You can't walk around with a broken arm forever. So what happens is your bone has to go through stages in order to heal. And that is often why whenever you get a cast, it needs to stay in a cast for a certain number of weeks to allow that bone time to go through these 5 stages of healing. So first off, you have that initial swelling or that hematoma formation. You probably have seen people who've gotten a broken bone or images and it's very red, swollen, and purple, bruised looking. That's the hematoma forming at the site. So the hematoma is going to form around that broken area of bone, and it's going to create essentially like a hematoma, like a clot, and it's going to help to sustain the injury, okay, in order for it to start going through the other phases. Cellular proliferation then is where we're going to have our cells start to replicate and try to repair that dead space that has been created from the clot, or from the broken bone at that clot area. Right, the callus then is where we start to try and lay the groundwork for the osteum to come. So for the bone to come together again. And ossification is where the bone tissue is starting to grow again to heal that gap or that area where the break is. And then remodeling is whenever your bone goes through a process and it kind of cleans up that ossification callus to make it a more functioning bone again. It's never completely healed, just like if you get a scar, it's never the same as the original skin tissue. You can often see old fractures on x-rays and things like that that people have had. But it's a way to make the bone stable again so that you can go ahead and have function and movement as well. When people have fractures, they can have complications. So some of the things we're concerned about if somebody has a fracture, for instance, would be infection. It's a lot higher if somebody has an open fracture, meaning that that bone is now communicating with the outside environment, okay? And if they have soft tissue injury because of the fracture, so that's more likely if they become displaced and the bones aren't lined up anymore. Especially if they're open, think about that. You've broken that barrier that your body has, and now you have opened it up for bacteria, viruses, and other infective pathogens to get in there under the skin and into your bone itself. Osteomyelitis can actually become a chronic inflammation and infection of the bone that is very difficult to treat. So osteomyelitis then is an acute or chronic infection of the bone. If it's acute, it can be caused because we had an organism that's entered in. So for instance, an open fracture, it can be spread by blood or skin to the infected bone as well. Staph aureus is a causative organism in 85 to 90% of these cases. So usually if we see somebody has osteomyelitis and it's acute, then we know that it's probably caused by Staph aureus. Chronic, one of the things we get, if we see as a hallmark sign, is that there's this presence of infected dead bone, sequestrum. So what you see then on x-ray is like these little bony islands essentially where we have bone loss within other bones themselves, and it gets separated from the living bone, and it's because of an infection that's going on. So osteomyelitis, so what happens is these organisms are going to adhere to the bone and start expressing these adhesive molecules that are going to bind to the bone matrix that we have within them. After they invade the vascular supply, the organisms then are going to trigger an inflammatory response, and then they're going to work within this enclosed space that they're in. They then, because of the inflammatory response, create exudates, and this exudate is going to infiltrate the canal that's in your bone, where usually your bone marrow rests. And particularly in kids, they may have extensive past the marrow area and into the periosteum because of their growth plates and things, and they can get abscesses or pockets of this infected bone tissue. They're going to have disruption of the blood supply then, because it's going to be blocking off blood supply to the bone that is normally there and healthy. And then as a result, the bone that can't get blood supply can get necrotic. You're going to often have a formation of a layer of new bone that surrounds this and makes it like an encapsulated area, but you can still have the spreading of the osteomyelitis within the region that it's affecting. And the inflammatory mediators are going to be released because of the phagocyte cells that are coming in to try and beat the osteomyelitis, essentially. But then they end up to generate these reactive oxygen species and cause these proteolytic enzymes that come. And what happens then is where they're trying to heal the bone, these enzymes actually cause more bone injury and they can damage the surrounding soft tissues as well. Another complication that we can have from fractures is compartment syndrome. So what happens in compartment syndrome is that the pressure of the intercompartmental area, so the area that has your fascia, your muscle, your tendons, your ligament, your bone in them, okay, it's going to actually get elevated. So the pressure is going to go up, and it's going to get confined by your myofascial compartment. So that's like your skin and things like that. Okay, and then the neurovascular structures that are in that space have all this extra pressure put on them, and they're not able to function. So from the outside, what we see is swelling and purple and decreased perfusion and things. And on the inside, what it is all that extra pressure that's created from that bone fracture and the hematomas and things going on inside is taking up all the extra pressure, and your nerves and your vessels then can't work properly. So what happens is that you're actually decreasing that size, the compartment size. Okay, so because we've added that structure or added that hematoma and that break and things within the structure, then you're actually decreasing the amount of work area the remaining structures have to function. And then you're increasing your compartment content because we're adding more to it that shouldn't be there. Okay, so if we have somebody who has compartment syndrome, what happens is that you can essentially kill off those nerves and that vasculature if you're not careful, especially to anything distal of the injury site. This is an image where the top one here is our normal compartment area with our bone, our muscles, ligaments, and things like that. And then down here we have compartment syndrome because we've had this bleeding and rupture and this leaking into the compartment area. What they do then is they have to do a fasciitis where they will take and lacerate the skin to allow a release of that pressure and any contents that are causing difficulty. Alright, so what you get then is the numbness and tingling. They're not going to be able to have any relief of pain. So even if we give them medication, ice, elevate it, they're not going to have relief of pain. They're going to have a lot of pressure. As that circulation gets cut off, they're going to have paleness and paralysis. And eventually the pulses that are distal or after that site are going to be absent. You won't be able to feel them. What we do then is we want to provide a prompt and accurate diagnosis. So we need to know this is what the situation is. We don't want to apply ice or elevate it above the heart because you're going to change that circulatory pattern in the area. We need to remove any bandages or any casting that is on the limb so that we can free it up for more space. And then they might need to have traction. If they're in traction, they might take down the weight and provide less traction on the area. And then a fasciotomy is where we lacerate that skin to provide decompression of the contents. Okay, so that is the first half. What I'm going to do now is switch over and we'll talk about the disorders of musculoskeletal systems next.